for state representation. This is relevant for today's topic because it's important to have ideals to strive towards. In the face of practical realities, we may not always achieve them. For you, it may be budgets, staffing limitations, attitudes, organizational inertia. So we have to think lofty in terms of health literacy so that we can move the agenda forward. Moreover, as Americans, we have more than one history that gives shape to who we are as people. El Paso is far from Philadelphia, not only in distance, but in your formation. And last night I was reading about Spanish explorer Juan de Oñate, who celebrated reaching the Rio Grande and having a Thanksgiving Mass 100 years before Philadelphia was founded, and how El Paso's history is intertwined with Ciudad Juarez. The histories of the Southwest and the border communities are not as well known as slavery and the injustices to our black brothers. But my father tells me about the signs, "No Mexicans or dogs allowed," that he and my grandparents would encounter as they traveled in Texas. Yet today, we have a Latina who is being considered for the U.S. Supreme Court, which is quite a milestone. And it's incredible that at the same moment in history, we have a Berlin Wall that's going up across the U.S.-Mexico border. In speaking to the shuttle driver, I was impressed at how fantastically different El Paso and Ciudad Juarez are in terms of raising a family and a place to live. So building a fence has many arguments, pros and cons. The idea is that we have ideals, but we have to work within our current realities. And for health literacy, this is a challenge that crosses many lines and one that requires small steps in the face of real and significant barriers. First, I need to make a disclosure. I am not going to talk about drugs or any medical devices, and no one is paying me to make this speech. So you can blame Jonathan for having me here. Okay, what I'd like to do today is talk about, the title is Approaches to Promote Health Literacy in Public and Private Sectors, and we're going to talk about language barriers in healthcare quality. And being in El Paso, it's a little like bringing coal to Newcastle or talking to the Eskimos about snow. So I'll do my best. I think I can hold my own on that topic. I also want to talk about the concepts of health literacy in the context of health communication with limited English proficient populations. How many of you here are medical professionals? How about policy wonks? Okay, good. Less threatening in the crowd. How many of you are bilingual? I expected that. Good. So this is not an easy subject. When we talk about practical solutions in communication, I think I have something to offer. As Jonathan said, I've been with the Hablamos Juntos program since 2001. It's an initiative of the Roderick Johnson Foundation that was funded to look at language barriers to healthcare with the idea of developing practical solutions. Learning another language is a fairly difficult task, so we aren't going to be able to teach people English across the country, so we have to look at practical solutions. And we focused on increasing the availability of interpreters, useful health materials, translation products primarily, and easy-to-use signage. The initial objective, we thought, was to build capacity, hire interpreters smartly, translate more materials, and then easy to navigate signage. I mean, I've been in healthcare at this point 25 years. We know we've been treating LEP populations forever in California. So this is not a new subject. In 1977, I developed the first interpreter program in the Children's Hospital where I work. So, I mean, how hard can this be? You know, over the last 20 years, we probably have some advances we can bring to bear to these demonstrations. The foundation was fairly generous with the grant. We thought we could make quite a difference. And it turns out it's a little more complex than we thought. Sometimes when you know something, you don't know how little you know about the subject or what you don't know. How many of you are runners? Okay, good. When you start to run, this is the experience for me, you think it's easy. I mean, running, we all do it. But then you get out there, and the first time I went out, I could barely make it to the end of the block. But I went back the next day, got a little bit further, back the next day, a little bit further. And within the first 2 weeks, I get what people call the runner's high, where you know you can run forever. You don't need to stop. You can just run, and it feels so wonderful. Now, if you're not a runner, you can't imagine what that's like. I mean, running is not easy. Or that you could run 18 miles. This body has done it. Others have run much more than that. But it begins with the first step, by building and going back and working on it. Language is the same way. We start out with a single word, and then we string them together, and then we learn about pleasantries and customs around the way that we speak. Buenos dias, muchas gracias. So we build on a little bit at a time. But languages are unique codes that develop around these customs and norms, and that evolve around how people transact and how you relate, what you think is important, how you express or whether you express ideas or thoughts. They're more than just markings on a piece of paper. When we began to look at translations, what this signifies became a little more evident. This is a translation from Spanish to English. Now, in this country, we're not used to translations from another language into English. If English is our dominant language, we don't have much experience with someone starting with another language and trying to convey those thoughts and ideas to us. So we don't know what our text in the brochures is that the speaker earlier was talking about, how people have trouble understanding the brochure. My question is, was it the content or was it the writing? This is an example from Spanish to English. From the largest lobsters and crabs, whose amazing appearance is matched by their amazingly rich taste, through the varieties of juicy prawns and shrimps, mussels and clams, what delicious flesh, and what more appropriate triple to ripple over your palate, like golden wavelets than Tio Pepe, as you savor the delights of his precious jewels of the sea. It's English. The words we recognize, some of the intent we get. But this is a label on a Tio Pepe bottle produced in Spain, and it's trying to tell you what a delicious product this is. Now, is this message compelling to you? Do you just want to go out and buy this Tio Pepe because this really makes you want to do it? In our work around translation, we found many examples of this type of language from English to Spanish. In one of the projects that we've been working on over the last 4 years is to try to understand why this happens. You know, we have translators who are trained and skilled, we think. I come to find out from linguists that training for translation unless you are in a foreign country, doesn't exist to any great degree, hasn't existed. We're seeing more of it now in the last 8 to 10 years. We're beginning to see programs that pop up where it is a discipline that you can learn. It's a linguist, writing, communications kind of a program that people are learning. Many of the translations that we get in this country are done by foreign-born translators who have been taught in translation schools. But much of it happens from, hablas español? Can you translate this for us, please? So much of what we find in healthcare is of this quality. And this is another example of what we are finding and should be fairly common. You've seen this before. You may have been in this before. No bueno, says the doctor grimly as he walks in with Barbarita's x-rays. He tells Mima, ask her if she's had TB. Mima turns to Barbarita. He says, if you have a television. Tell him yes, but in Havana, not in Miami. My daughter has a television here. Mima tells the doctor, she says she had a TB in Cuba, not in Miami, but her daughter has TB here. In that case, the doctor says, we need to test her for TB too. Mima translates. He says he needs to test your daughter's television to make sure it works. Otherwise, you cannot get your green card. Why the television? Asked puzzled Barbarita, looking at the x-rays. How many times did I tell you, you need to buy one? Don't you know, Barbarita? It's America. Okay. The most common translator in healthcare is a friend or family member. My sister takes my parents most of the time, and I know her opinions and her ideas about what they need to do and communicate it, she is leveraging through her role as an interpreter, as this woman is leveraging her opinion about what Barbarita ought to be doing and getting that television. Our work early in 2000, I think, has helped raise awareness that interpreting is more than the ability to speak the language, particularly in healthcare. And we're going to talk in terms of health literacy, how health language is indeed a foreign language to many of us, whether we speak English or not. So here you have intermediaries, often untrained, and what we did in our demonstration was to help train interpreters who have the role of conveying critical information, soliciting information, presenting potential options. So very important. With our grant, we were able to fund 10 demonstrations. We gave them $1 million each to work with us. They were all in fast-growing Latino populations, and we were looking for different solutions, different implementations based on the different settings. And so our host communities were very different. Our language acquisition histories were very different in those communities. How the health systems were structured were also different. And I'm a social worker by training. I spent my first 8 years in healthcare in a children's hospital trying to help parents understand what was going on with their children. From a trauma to a drowning to a diagnosis of cancer, helping folks understand what was going on around them and helping explain often, the settings that they were in. And in that experience, I did an awful lot of interpreting. I spoke Spanish. I was a natural interpreter. So as a social worker, worried about the psychosocial aspects, sitting with a doctor who's trying to explain why this 7-year-old needs to have a shunt replaced, just had it 2 years ago, why does it have to happen again? He goes into lots of descriptions around how the body grows and what a shunt is and how how it works within the brain, and how there's fluid that we normally develop normally, but that our bodies naturally have a way of dissipating it, and the shunt replaces that function when it doesn't work in a child's head. So it wasn't just the language, it was the concepts, the words, the situation that they were in, the emotional content. And here we have interpreters who are doing this, just thrown in there. When we started to bring translators into hospitals that didn't have them, to health facilities that didn't have them, one of our biggest obstacles was that the health professionals didn't want to use them because they already had worked out a system. You know, the registration clerk was closer. They had more confidence in the janitor who they've been working with before. It was too complex to pick up the phone and to call someone they didn't know, they didn't have confidence in, they didn't know who knew what they were doing. So we really had to work at getting the system to accept trained interpreters. So I think part of what came out of our initiative was that we have more of an emphasis in training and looking at certifying interpreters today. I think we helped move that forward. There are more training programs that are available for interpreters, and testing of language proficiency is now a topic that people are interested in and looking for resources to solve. We also created a toolkit for, it's called More Than Words Toolkits, to start to break down what is the translation process, and how does that work, and how do you give instructions to a translator? Because most common what we have is, here's a piece of paper I need translated, you're willing to do it, could you please translate this into Spanish for our region, for the nation, Hispanics across the nation, with little instruction about what is the purpose and use, and what do we want to come out of this reading of information, so that all of that goes into the writing of the English original. It needs to be understood by the translator. So this toolkit is available, and then later I'm going to talk about the work that we did around signage using graphic symbols. But together, this experience over the last 8 years has created a conceptual shift in our thinking about language and what it means more broadly to health communication, and how health literacy fits into that, the important implications to healthcare quality and safety. Patient safety and quality of care depend on effective communication. We've come to understand that. And communication is a cornerstone of patient safety and healthcare quality. If you have these aberrations, if you have these distortions, if you have these materials that aren't getting across the information that you want people to understand, communication is affected, and patient quality and patient safety are likely to be affected. Also, we learned from watching videos around interpreters that often interpreters understand this role, and they fill in gaps that are not necessarily language-based. Some of these complications or gaps, in just explaining what's going on, an interpreter can fill. Who fills them for the English speaker that's seen a doctor for the first time around a condition that might be fairly frightening? Who helps them ask the questions? And interpreters who have become good, and there are many, many good interpreters who have learned through the school are not, like I learned how to do social work, although I had a basis of training, it's different in real life. And to be an interpreter in that setting, you learn what makes sense, because you understand the system broadly. You understand what the doctor wants. You understand how the nurses use this information, and so you can pull it together and help people navigate. But who does this for people who don't have interpreters? Not just in the language, but in the systems that we find ourselves in. We also came to understand that health literacy has something to do with the individual's ability to comprehend, but it is much more than that, as I was describing earlier. It's a familiarity with the processes, the environment, the rules, the practices, the social aspects of how people interact within a health environment, and they're there. You know, the nurse, the doctor relationship, you've seen the literature probably on that. The role of the ancillaries who are very expertise in a machine but have no idea of why you're getting this test. And we expect them as agents of our health system to at least be able to tell us what are they looking for. But that's not their job. Their job is to push the button and to run the computer, and they've been taught. Don't even try to explain because it'll just get you into deep water very quickly. It's a doctor's role. The language that we speak in healthcare is often not English. So we have a communication challenge. From our linguist friends, we've learned that words have no meaning. They just have the potential for meaning. And that potential is learned. Just as we're learning our language, we're associating some notion that goes with that word and when we use it. And they're different. They're informed by our external world. They're informed by the context, which is the health world, and our personal world, the human drama, the stuff that we live with, the histories that we come with, the stories that we've been told about a condition. So the challenge goes beyond hiring interpreters and translating materials. It's really understanding how we communicate, how we say what we say to people, and how do we validate and verify that our message got across.
Excuse me, could you read us the left circle?
Yes, that's why I was putting my glasses on. It's the health world, biomedical, high-tech, unique administrative structures. I'm working on a little project right now with LA Health Plan around the vocabulary that they use for their promotional materials to enroll people in the health plan. And the goal of the project is to identify terms like health plan, benefits, arbitration, words that are unique to the way that we pay for healthcare, that as health users, we have to navigate. You know, when they tell us, you know, you have the opportunity to get a second opinion, or we need you to fill out a treatment authorization request, or you have to go back to your primary care provider. Those all have meaning in the context of the health delivery system. To us, they're as foreign as another language. So the healthcare world itself is designed to have terms that are not common use. We also have biomedical terminology. When physicians go to medical school, they will learn between 6,000 to 10,000 words in their 4 years of medical school. That's equivalent to a different language. It's for every little tiny bone in the body, for the different stages of certain diseases or different types of swelling. They have a whole of language that they use to be precise and to convey to their cohorts what the issues are when people are working as a team. These are part of the barriers for us in health communications. You know, with language barriers, we know that there are navigation challenges, that there's confusion and sometimes inability to express what it is that we're looking for. We find research that tells us low satisfaction when someone doesn't speak English and they're getting health care, and their increased risk of inattention and poor care. And the same can be said for populations with health literacy, except we're not doing studies on that to find those yet, but it's emerging. From a provider perspective, we know that language barriers interfere with making an accurate diagnosis and giving important health information, in meeting the standard of care and getting informed consent responsibilities accomplished. We know that it's a barrier. Offering and explaining healthcare options. I mean, we've seen focus groups that say, they're not going to understand anyway, so why should I explain these options? And engaging patients as partners in their own care. And so much of healthcare is moving towards your being an active participant in your care. And the same can be said about populations with low health literacy, where doctors just feel frustrated and say, I don't think they understand, so let me just make it very simple and tell them. Don't give them the choice, just tell them what they should be doing. These are natural responses to barriers we don't know how to resolve. And there is emerging evidence that ineffective communication places patients at greater risk, and that disparities in health status and health outcome are more frequent in populations that have language barriers. We think limited English populations are like the canary in the coal mine. The canary, when the miners saw the canary pass out or die, they knew there was a gas leak and there was danger and they needed to exit. So for us, looking at language barriers helps us understand how health literacy works. And communication is more than words. The Institute of Medicine tells us that health literacy is a serious problem with the potential consequences in the billions of dollars in avoidable healthcare costs. Patients with limited limited proficiency or limited health literacy have higher rates of hospitalization and emergency room use, as we see with the LEP populations. When they have low literacy, the consequences are more severe of wrong site surgeries, errors, and avoidable death, simply because they're not understanding what it is that they're asking, or even, I mean, I've seen patients who say they weren't even sure what the doctor was doing when they consented to the surgery and come out with a prosthesis on their leg. They didn't realize the connection wasn't made between the discussion they were having, the signature on the form, and this new prosthesis, English speaking. We expect to look for that. We have fear about that for LEP populations. We don't expect that for people who speak English. And it's been defined as the degree to which a person can obtain, process, understand basic information and the services needed to make appropriate decisions regarding their health. When we think about chronic disease and what patients are having to navigate today, these are important skills. It's not just receiving the information, it's understanding it. It's being able to take and follow through, to connect one piece to another and make a decision that I should probably ask this question, or I should ask the doctor to check this out, or I should ask the pharmacist, are these two medications okay for me to take given this condition? People with low health literacy don't have those kind of navigation skills. This slide isn't going to work, but it's transitioning into what we are doing to create practical solutions. And one of the areas where we thought there was low-hanging fruit that we've been working on for the last several years and are now in phase 2 is a project to create symbols. And this is a 2-minute clip of a news coverage that was done when we finished our first phase, and we came out with a set of 28 symbols. which you'll see later. But it basically describes the process that we use to do the testing. It was fairly elaborate. We had 3 rounds of testing using a methodology that's been adopted by the International Standard Organization, an international standard setting organization, with 4 different language groups, English, Spanish, Indo-European languages, and Asian languages, to find symbols, images that would resonate with particular references. So I apologize if that isn't going to work. We started that project with the basic assumption, is it possible to talk to people in pictures? And we found that pictures or pictograms have been used since the caveman days. I think in this region, certainly in New Mexico, you'll see evidence of pictograms that have been painted on walls as a way to capture stories and to document that some event occurred. We also find that symbols are being used as a practical tool in many countries where literacy is very low. This is a ballot in an Arabic country, and a symbol is assigned to each candidate, so when they go out and campaign, people recognize the image, and so when they go to the ballot, the goal is to click on or mark that particular symbol if you want that candidate. So in effective communication, we have to look for the social and cultural context for understanding, as with the ballot. And in healthcare, for things that shape behavior of individuals, families, and communities. We also have to think about the belief systems, religious and cultural values, group identity. All of these are powerful filters through which information is received and processed. And these cultural processes and lived experiences contribute to the worldview that people come with. Lived experiences is an anthropological term that talks about how we experience the world and things that happen to us shape what we believe. If we can go back to the early times where we believed the earth was round, that was their lived experience. They would not get on a boat and go, they thought people who got on a boat and went across the ocean were crazy because something was going to happen to them. They were amazed when people went across the ocean and came back and told stories that there were other lands. That didn't fit with their lived experiences. That happens to us every day, and we think everybody thinks the same thing or sees the same thing, that we share these experiences. We often hear in conversation that we do have some things in common. We often have the same breakfasts, we probably see the same shows, we know the same characters, and media is flattening the world very much. And the dubbing of English commercials and English movies is importing some of those dramas and stories into other countries. So we have to keep that in mind as well. We have to assume that there are cultural differences, not just because of the color of our skin or where we come from, but what's happened to us in our lifetime. How we experience the world, what we do, what values we were given. We have to assume cultural differences and to be surprised and be ready to be surprised that what you think is may be quite different. So when we're putting symbols together, we talked about the icon for the women's bathroom and the dress, and some of the folks in the room were saying, but men wear dresses too. Depends on what country, what their customs are. So testing our assumptions about what we think are acceptable practices was an important lesson. This is our set of symbols. I could spend an hour just talking about what we did with them. They're designed to be used in wayfinding systems, signage systems. We're in our phase 2, we're working with 4 facilities to implement them as a part of the wayfinding system, and we're looking for the practices for how to do that. We tested this, as I said, with 4 different language groups. We were surprised at how much commonality there were in areas we did not expect. For example, the chapel that's up there is an environmental icon, and there are many different religious practices that don't include a chapel. But we think that living in the environment where chapels exist, in a country where religions dominate, where chapels are part of it, it doesn't take long for someone to figure out that's a chapel, that's where people go to worship. It may not be how I do it, but I understand that that is. We were surprised at the teddy bear for pediatrics that was recognized across different groups readily. That's a personal icon where you have to, engage with it. And we think television and children's programs and children's demand for toys and the toy stores that people walk into in this country, bears become very familiar and associated with children. So that association was understandable. For the lower half of the symbols, we didn't meet our threshold. Our threshold was 86% recognition by the subjects that took the surveys. The second half didn't reach that 86%, but some of them were fairly high. Interpreters was fairly problematic because it was hard to graphically convey this process of exchanging information through a mediary. Diabetes didn't score as high, although it got into the 70s range, but we think populations who have diabetes are more likely to be familiar with the fingerprint and could recognize it. And I recently got a phone call from a woman who is putting together a toolkit for diabetics in case of emergency response toolkit, and she wants to use our symbol because she believes that diabetics would recognize that to a higher degree than the general population. So there are some icons that will have to be learned. This is a starter set. As I said, our next stage is to actually implement them and to see what happens in these facilities and to develop some best practices. We have also developed a consortium of design schools that are working with us to, we've got probably 200 or 300 students that are now involved in thinking about symbols used as a way to navigate facilities. And we've got some great artwork to be able to expand this and are now working on testing methods that will include the students. From our work, we've concluded that language access has to be a core function for all health organizations, and that leaders and decision makers need to make the connection between communication and quality of care in tangible ways to improve communication for all patients. And as I said, if we see and learn the challenges of people who don't speak English, we can also think about those challenges in the context of English speakers. And it is a condition or a factor, much like age, sex, or religion, that needs to be part of your decision tree in how you organize and design the way you deliver your services and how you present information. We think that we ought to be thinking about this in the context of new technology, and computers give us much more capability to be able to tailor communication, print communication, telephone interventions that take into consideration both language barriers and these health literacy challenges. But it's a dual-edged sword. New technologies may also exacerbate these inequalities in health and health care, or it can be a solution for reaching populations. Attention to access, acceptability, availability, appropriateness, and applicability are all factors that need to be applied in evaluating the use of new technologies for diverse populations. And then we think research, there is so much that we need to learn about communication challenges and the way that we deliver care today. We also think we ought to think about diversity very differently than we do today. It's not just race and the socioeconomic conditions that we all read about in our research. It goes beyond that. And to anticipate differences, as I showed with that slide around our impression around what a woman looks like, and to look for more meaningful ways to understand how life experiences and cultural processes contribute to within group variations, how these affect health behavior. Customization is the key. I mean, you can have it your way in almost every other sphere of our social life. In healthcare, we have to get there too, and I think this is why we have put such emphasis on creating technology or bringing technology into health organizations, because we're going to need that kind of support. What works for one population or one individual may not work for similar populations or similar individuals. Behavior change and communication theories, we ought to apply them, not just develop materials because we've been there, we know this, we know the population. We need to go and look at the theories that are out there and incorporate them into our tool development. And as we were talking about earlier, it's good to have these ideals to understand all these complexities, but to be focused on solutions that can be applied today that have real effects on outcomes and barriers, and evaluate before we spend hundreds of thousands of dollars translating materials that really are not communicating the messages that we want to communicate. This is an example funded by the American College of Physician Foundations, where they've taken basic diabetic instruction and they went out and talked to users and said, how can we, what do we need to tell you in order to help you address your diabetes? And from that came a very simple 8-page brochure that's available from the website at no cost. I think there's a $1 charge for each of the brochures. It's been developed in English and Spanish, and they're now working on a COPD, which has a lot of pictures, which has examples, which has little tools. I mean, one of the very basic things that people said when they talked about diet, how much is enough, was one of their biggest challenges. So creating a picture where you had a balanced diet, which is the little card at the bottom, which is now a handout and a magnet for the refrigerator, so that people knew what we were talking about when we asked them to eat a balanced diet and how much fruit and how much vegetables. And in summary, we have to think about health literacy in the individual and the U.S. health system context together, because they influence one another. Practical solutions, this is where we start. They're expedient, but they're a dual-edged sword. We may be, navigating in the wrong direction, so be ready for mid-course corrections and be ready and continue to gather data to make sure that these beautiful things that you've developed and these premises that you've based these solutions on actually hold up over time, hold up with different populations, hold up in different settings. So continue to test, examine your assumptions, ask people. I can't tell you how many times I've been surprised because I thought I knew the answer, and then I get something that I totally, blew me away in terms of what patients thought and understood from particular words and practices. Separate out the economic factors that contribute to social conditions, education, and exposure. Some of what we're looking at is related to poverty. Some of it is related to the way that people have to structure their lives. So these are not social, cultural in the context that we're talking about. These are real barriers that need to be overcome. And it doesn't matter what language they speak or what color their skin is. So we have to separate those out Education is a big one. We know that there are barriers, but just because you have a college degree doesn't mean you understood what that colonoscopy was all about. There's evidence to show that engineers have just as much of a problem navigating the healthcare system as an LEP patient sometimes. They're better at asking questions. They're sometimes better at hiding what they don't know and harder to help, but it crosses all economic and educational levels. And also the other piece that I think we don't do enough about is account for the commingling of subcultures and the rapid pace of information flow. Traveling with my granddaughter, her agility with values and ways of living to other countries, but they're not adopting them as we would. So they come with a little more understanding or a perception that we need to sort of understand from them. So the ambiguity that we're working with is very high. Our ability to discern, are we on the same page? Am I addressing what you're needing? Are you able to convey to me? Am I understanding what you're conveying to me? All of this has to be part of what health professionals learn in treating populations in this very diverse country, in a very diverse world. And that concludes my comments, and I'd be happy to answer questions. Happens often. There's so much there, you just go, don't go home and sleep on it.
I have a question.
Sure.
The issue came up again about the authority of the physician in the doctor-patient relationship and the difficulties there. And it seems to me that workshops that increase sensitivity and improving communication skills from the physician's side would be important to get them to learn about how to simplify the language and talk in normal language for the patient. Do those exist, and to what extent do they exist, if you know?
No, those are one of the strategies, and there are a number of models that are out there. There's about at least 8 models that provide physicians with some guidance on how to break down why a person came into the room, and assessing cultural differences, a line of questioning where you can ask, to solicit to make sure you understood. One of the most effective techniques that I think works is to simply ask the patient, to know that you're having to potentially customize what you're saying to a patient. And so stepping it down if you think you need to, or stepping it up if you think you need to, but then asking the patient, can you just tell me what I described to you, or tell me in your own words what you're going to do next. So those kinds of feedback strategies are what I'm finding to be the most effective, that physicians can handle. From a physician's perspective, from a research perspective, I'm overwhelmed. From a physician's perspective, who's sitting there every 7 minutes with a new patient, trying to incorporate all of this into one interview is mind-boggling. So I can see why they're angry, and I can see why we have a shortage of internal medicine and primary care physicians, because this is where the complexity is. I just want to be able to take out your appendix, okay? Don't tell me about anything else. Just your appendix is all I care about. Those doctors will have a little more limited domain and can work around concepts and ideas around that particular procedure. But for generalists, they've got the whole, Pandora's box there. So one of the easiest way is to say, tell me in your own words, what you think is going on here. Here's what I think is going on. Do you think that makes sense? So some of the engaging the patient to validate what you think is happening are some of the basic strategies that I think people are using. The other is building systems where the final conclusions are written down and repeated several times by you in the interview, by the nurse who's processing the patient out, and then giving them something in writing so they can take home. So you create redundancies in a message so that there's a chance that they'll get it in one of the 2 or 3 times that they hear it.
Yolanda, I'm interested in the family dynamics. Oftentimes, and I'm going to just provide a scenario. My mom is diabetic. The doctor who's from India asked her, how are you doing? She says, I'm doing fine. And then my sister said, no, she's not. She's sleeping a lot. You know, so I think if you would have relied just on the patient-doctor relationship, it would have been truncated. So it's the older child who came in and had to translate, explain. And then when we realized she wasn't taking her medications because she couldn't pop open the bottles, right? And we call her every day, are you taking your medications? Yes, I am. When I realized, I said, you know, she's not taking her meds, she can't open them. So, you know, the doctor prescribed medication, assumes she's fine, she reports being fine, but she's sleeping on the couch for long.
Yeah.
So it's the children having to call, we're all calling online or computer, phone, how is she doing? She's sleeping a lot, we'll talk to the doctor, who's gonna go with her next? How can we negotiate the patient-doctor relationship as a family when we're all kind of scattered about?
Yeah.
So, and I also grew up translating for my parents a lot, and I don't know how we did it, we just try to figure it out.
Yeah.
So I oftentimes, when I'm talking in the health profession, I said, you know, the older child is like the third parent.
Yes.
Because when I would come home from college, I was the third parent who had to help my parents make the decisions for retirement, for the mortgage, for their healthcare system, and I didn't know what I was doing, you know. So there's this cultural component I think that we have to keep on inserting of who's making the decisions at the household level, who do I need to communicate with so that we make sure this patient is being taken care of.
Yeah.
And then when we have so many elderly people living alone, I think there's a huge breakdown in the delivery of care.
Yeah.
Because what is communicated from the doctor to the patient is not oftentimes executed at the household level.
Yeah, yeah. Well, the good news is there's a good friend of mine who is doing some research in the power shift that happens when children are asked to interpret. And she is looking at, you know, the use of language. And that there are actually some skills that these children develop very early because they're thrown into these social settings to arbitrate and negotiate on behalf of their parents. So they're put in a parent role and they're put into situations, transactions that as children you would experience. So there are some good news that are coming out of that research, which is kind of fun, and I'm glad that people are doing it. The sandwich generation is what you're talking about, which there are many of us, you know, who are old enough to have parents who need protection, and it is family specific. It is, you know, an influence of your economics and your culture and your environmental circumstances. If you live in town, we have some opportunities. If you don't live in town, those opportunities don't exist as easily. So that it is a lot of negotiation, and every family has to sort of work it out. And I could tell you about the discussions I've had with my sisters, with my 2 parents who are still alive and fragile. But I think from a physician's perspective, the requirement is to know that there's all these different kinds of family patterns, and sometimes contributions from children are okay, and sometimes they may not be. And you know, elderly people they also need protection. They also need to retain their autonomy. And as they're losing their abilities to navigate, it isn't because they want to, it's because they can't anymore. And so how do you allow that person to express their interests, their wishes in this dynamic? And you're sitting there with, you know, 7 or 8 minutes to try to figure this out. Relationships over time are important. So if you can build a relationship with a primary care physician, that's probably one of the best things you can do, so that he becomes more aware of these family dynamics. This isn't the only time you're going to be dealing with. There are probably others in other circumstances. Finding ways to determine what are trusted sources within these dynamics. And you're using your judgment as a physician is this the doctor I listen to, or is this the doctor I don't listen to? Is this a circumstance under which her wishes are more important than the patient's, or how do I get that from the patient when she isn't able to give that to me? So there is a lot of understanding that all of these dynamics are at work, and sort of walking through very, very gingerly. The doctor-patient relationship is the most important in terms of how they communicate. And I think that physicians who sort of develop a practice for a good portion of their patient population do this well. It's always the outliers. And so we're not talking about every patient that they see. It is a small minority, but a critical minority, where some of these issues need to come into play. And as I started out earlier, there are the ideals that we're shooting for, and then there's practical realities that will continuously challenge us. But it's important to have these ideals because they serve as a beacon to where we want to move ourselves to. Maybe with technology, some of this stuff will get engineered so that some of the guessing is left out. You become more efficient at it, but it really is a human interaction kind of thing, and beginning to know someone over time. Other questions? You just had a break, so you should need one. It's too early for lunch. Question back there.
Well, more than a question, I'm going to make a comment. My first experience as a researcher, a long time ago, in 96, around 96, 94 probably, I was doing some research with Mennonite population. In my hometown, which is in Mexico, we have a huge colony of Mennonite people. So I said, I'm going to do research. What am I going to do? Apples. Well, we have apples or Mennonites, and started with Mennonites. And my experience was very something to talk about just because of this. We developed an instrument to ask about chronic diseases like diabetes, hypertension, kidney disease, liver disease, some kind of stuff like that. However, we invited a nurse, she was a Mennonite, and we said, okay, this lady is going to translate the questionnaire. She did it. But at the moment that we were starting to work, the Mennonite population, they don't know how to read, they don't know how to write in their own dialect. Not German even, which is dialect of German. So we have to try to explain them in our own words, whatever we want them to know. So the questionnaire was kind of useless. It's just an example.
Yeah, understanding when you don't know enough in order to be able to create categories even. Yeah, and some of this is that way, where you just have to sort of peel back the onion and see really what's underneath there. You had another question.
Yes, I'm guilty of this when I've gone to the doctor's office, but it seems to me that we hardly are ever in that environment, in that situation, and so that when a physician comes into the examination room and asks, how are you doing, the automatic response is say, I'm fine. And the first thing that blurts out of my mouth too, and I say, no, wait a minute, I have to come, and if I have to think about what answer I need to give him, I can just imagine how much tougher it is.
I worked with the Alzheimer's Association in Los Angeles on another project where they were doing courses for caretakers on how to be good intermediaries in physician visits. Because this is what would happen. They show up, I'm here for a doctor's visit. Okay, so what preparation? Why are you here? What do you want to get from the doctor's exchange? We don't think that that's our job. So we're teaching, our Alzheimer's Association is teaching caretakers who are responsible for these patients how to record notes at home, how to prepare for doctor visits, to bring all their medications in a bag so the doctor sees them, to write down 2 or 3 questions that they want the doctor to answer, to have a key thing that they know they're going to walk out of the doctor's office with, or they stay there until they get that key answer. But you have to teach people how to become patients. We have to do more of helping people understand that we have a role in our health, and that doctor is an instrument. You know, a wealth of information can help me, but I need to be able to articulate, you know, why I'm there. I worry a little bit with all the, because I'm a Kaiser patient, and so they schedule me for visits, and you're there for some kind of preventive stuff. So you're a passive patient, and we need to be more of an active patient. And in the world of tomorrow, it's going to be us navigating, and the doctor being a resource. So we have a ways to go in building that culture.
Adding to that, I work for the Alzheimer's Association here in El Paso, and we do try to educate the caregivers as far as to ask, but not only the caregivers, but also any caller that we get to encourage prevention, early detection, awareness of the disease. We try to make these tools available through the internet. We mail them out. We have copies in our office when we get the care consultations at the office, and they've worked wonders. You know, a lot of people, it's working.
Yeah, I think it was Pfizer who did the Ask Me 3 project, which has 3 basic questions you should be asking your doctor when you go visit. And they're also trying to promote awareness that we are part of the care team, and it's our job to help the doctor help us. So there are at least 3 questions you should be able to ask your doctor to make you participant, active participant in that visit.
I think I'm going to turn it back on our audience a little bit on this one, just because I see that we have some nursing students here, and in my previous work on the other grant, we clearly identified that language is a big barrier to care. So one of the things that we did is we gave each one of our student PAs that had in them a English-Spanish translation, as well as faculty. Madrid Capone here, Zora Rodriguez. And so I want to kind of hear from some of the students about if it helped to facilitate when they are doing their rounds, and also from the nurse's perspective. So either Irvin or Laura, whoever wants to go.
Well, I work in acute care, and I'm adjunct faculty with UTEP. And what I have found is a lot of the stuff you talked about is a lot of the stuff that I've seen in my own personal experience. But I think, like you say, we've got to close the gap, because I find myself also translating, and sometimes I wonder, even though I consider myself very fluent in Spanish, and I've not had to use the aids as much as maybe somebody else, but I sometimes wonder, did I leave something important out? And I think it's good that we've brought national attention to being involved in patient care, and what I mean by that is you have the National Patient Safety Goal now that states that you must involve your patient in their self-care. And I thought, a lot of times I think we all hem and haw about, oh, here comes another National Patient Safety Goal. But this one that came out about involving patients in their care, I think is going to be good, because I think it's going to force people to say, yeah, you know what, I really need to think about what I'm saying to my patient.
Mm-hmm. Or more fundamental, I think the shift that you're seeing there is that patients are no longer passive.
Passive participants.
You know, that they are agents.
Mm-hmm.
And so when you see yourself engaging with an agent, the way you see yourself changes. Mm-hmm. If the patient is there for you to take care of them, they're passive, then you're not thinking about engaging them. You're thinking about taking care of them, make sure the vitals are, all the recordings down, the medications are right, and you're just sort of focused on doing your job and doing it well. The paradigm shift is now you're now being asked to think about the patient as an agent who has distinct role, rights, responsibilities, and they may not, that you can't just assume you can do that. You need to ask permission. So it's shifting the way that paradigm works.
And many times patients are surprised when you ask them questions that ask them to participate in their care, because they're almost like, well, I'm here in the hospital, you need to do everything for me and teach me. And it's also a paradigm shift for the patient and the culture in general, because now we're asking them questions. And sometimes they're not sure, oh, well, you really want to know what I think about this, or this?
Mhm.
It's very interesting.
Well, I think also that the health literacy area has helped broaden the way that we think about language barriers. I remember a young physician after a talk like this came up to me and said, but what are we doing about patients? I mean, it's good to have interpreters, and I serve as an interpreter all the time. She was telling me that when they grab me, and I don't have time to do it, but I don't want to not do it because this patient wouldn't get the information that they need. So there's this bind that we get into as professionals. But she was saying, interpreters, what happens when the patient is by themselves in a room day after day, and all these different people are walking in a room doing something or another? I can only imagine. And she says, I just finished talking with a patient who was just saying, who are these people and what are they doing, and why do they do these things? Am I dying? Because no one talks to me. So the idea that language and communication isn't just episodic when the doctor needs to tell you something or when the nurse needs to tell you something. That it has to be built into the processes. The patient laying in the room day after day, someone coming in and turning the lights off or turning the lights on. There has to be a way for that person to acknowledge, even though they may not speak the language, to acknowledge, I'm in your room, to hold up a card that says this is what I'm doing, or to have some kind of a way to communicate that basic courtesy. This is what's going on in your room. So it has raised our understanding about these issues well beyond the transaction of back and forth, although that in itself is extraordinarily rich. And we have yet to solve that problem.
To an extent, I'm a limited Spanish proficient individual, but all nurses are required to do patient teaching. But I foresee the patient teaching sometimes being a one-way street, that in order to accomplish everything you need to do, you do give your patient teaching, but do you know if your patient actually learned? And when I go in with a Hispanic patient, I do the best I can with my Spanish. If someone's available for translation, that's very helpful. But instinctively, I try to ask the patient to almost regurgitate what I've said. Can you tell me?
Sure.
And my last experience was telling an 83-year-old lady that she is a newly diagnosed diabetic. And she understood all of that. Went through how she would test herself. She would tell me all that. And then I asked her to recite that to me. And it just happened her grandson was there at the time. And my understanding is much better than speaking. He smiled. He said, you did a good job. I understand. And she told me back everything I told her, and I thought, success. And her last statement is, but I'm not diabetic. And I thought of the person right before you saying, this is the way God has it planned out for me. No, at my age, I'm not diabetic. I will do this, but I'm not a diabetic. So how much does that accomplish? It's like, should I do this regularly now? I have no idea.
Well, what you're addressing is a little bit. It is part of the interpersonal dynamics that are going on that you somehow have to manage with this whole diverse group of people that you're having to take care of in one day. So it is there. But even when you think you're doing a good job, and one of the stories I used to tell, I haven't told it in a long time, is about a diabetic patient who was not taking his insulin, and they went into a patient education session that he did very well. They were teaching him to inject insulin in a needle. He had to give himself his own injectors. He didn't have anyone to do it for him. And so he did very well in the demonstrations, very well in the trainings. So they thought he was going to do better, and they were completely surprised when he came back and he was still doing badly. And they asked him, you know, are you doing what we told you? He said, oh yeah, I'm doing it religiously, and he told them repeated exactly what he'd been taught. So what's the problem? Finally said, one of them said, why don't you show me what you're doing? So he reaches into his bag, pulls out his little, all of his little paraphernalia, pulls out an orange, gets the injection, injects the orange, and then eats it. So we thought we were telling him, we thought we were communicating. He got it all right. He did exactly what we told him. There was some missing link, and that happens all the time, all the time. I mean, there's just, and you just pay attention to that in your own life and the way that you're describing to people. You know, honey, I'll meet you at such and such, restaurant. Oh, there's two of them. You're the other one. Oh, sorry. We just didn't quite communicate. We do this all the time. We make assumptions about what we think we've said and what people understand, and they're nodding and agreeing. So we have to find ways to validate and verify, as this, person did, to show me what you do. Well, you've been a great audience, and it's been a fun time being up here talking with you.